Hello, and welcome to ID Talk, answers from infectious disease experts. I'm Dr. Scott Olson, a pediatric infectious disease specialist at Banner University Medical Center in Tucson and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. And if you're looking at the thumbnail of the podcast, Dr. Price is the distinguished young man on the right, and I'm the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thanks for tuning in today. This is the week of May 5th, 2025. Let's go ahead and jump right into our questions. Our first question today comes from a member who asks, are there any new findings on the relationship between long COVID and the amino acid taurine for the pediatric population? Now, I'm going to admit this was a fun question to go through because I didn't know a lot about the purported associations between long COVID and taurine. But before we get into that, I think it's important to go back and review a little bit the phenomenon of long COVID. So if we get in a time machine and go back to 2019 when COVID first emerged and then rapidly spread through 2020, we started to see a significant number of patients who were experiencing prolonged systemic symptoms following the acute COVID illness. Since that time, there's been a better case description put forward by both the CDC and WHO to help us diagnose long COVID in our patients, and they differ a little bit. So the CDC uses the definition of persistent symptoms greater than 4 weeks after the acute COVID illness, because in some individuals, recovery from the acute illness can last anywhere from 4 to 12 weeks. The WHO defines long COVID as symptoms lasting at least 3 months after the acute infection. So our definitions vary a little bit between the US and other countries, but I think we can say that individuals who are experiencing persistent symptoms 2 to 3 months after a diagnosed COVID illness could be characterized as long COVID, or PCC. When we look at the associated symptoms most often described with long COVID, studies early in the pandemic showed that the most common physical symptoms included fatigue, dyspnea, and chest discomfort, while physical and neurocognitive symptoms included PTSD, impaired mentation and poor concentration, or brain fog, and anxiety and depression, with greater than 50% of those surveyed reporting a reduced quality of life. And when we look at how common the diagnosis of long COVID is, studies in 2024 have suggested that about 7% of adults have experienced symptoms following a COVID infection, with possibly higher rates if infected with the earlier viral variants. Similar to the decrease in severe disease and multisystem inflammatory syndrome that we saw once Omicron variants became the predominant circulating strains, likely due to the decrease in inflammatory response that the newer variants tend to generate. As I mentioned previously, these estimates were based off of adult patients, and there's not as much data about the prevalence in children. But small studies do suggest that there is a higher incidence among those children who were either hospitalized with COVID or had more severe disease, compared to lower rates among those managed as outpatient. The good news here is that studies have demonstrated lower rates of long COVID or PCC symptoms among those individuals who are vaccinated against COVID-19, though the full magnitude of this effect hasn't been well described as far as I have been able to find. And part of the difficulty with managing long COVID in patients is that because we don't fully understand the underlying etiology of these symptoms, it's really difficult to determine what the appropriate therapeutic intervention should be. Currently, my best guess is that the persistent symptoms are related to the degree of inflammation that's generated during the acute infection. And we do see similar prolonged illnesses following either EBV or mononucleosis infections and Lyme disease, with some patients experiencing weeks to months of similar symptoms after an acute infection. And when managing patients like that in the past, I've used a combination of physical therapy to focus on the deconditioning that occurs from the acute infection and cognitive behavioral therapy to build coping mechanisms during the healing process if the family is comfortable with this approach. Additionally, reviewing the patient's sleep habits is important because if their illness significantly impacted their sleep schedule, focusing on sleep hygiene to aid in recovery can be really beneficial for some patients. And reviewing the literature on managing symptoms of long COVID, it does appear that similar approaches have been evaluated with evidence of benefit when patients are experiencing these prolonged symptoms. In addition to these interventions, some studies have looked at pharmacologic approaches to treatment of long COVID, with some potential benefits demonstrated with the use of hyperbaric oxygen therapy, metformin, and combination of low-dose naltrexone with dexamethasone. But I have to say that I'm not fully convinced enough yet of any of these approaches that I would be recommending their use in pediatric patients. So that brings us back to the original question of the association of taurine with long COVID. Now, this was not something I knew a lot about, so I did have to do some digging and found some pretty interesting data. So taurine has known antioxidant, anti-inflammatory, and cytoprotective effects. So some recent studies have looked at the potential link between taurine levels in a patient and the development of long COVID or PCC. A study published last year in PLOS One by Korumju et al. Found that of 117 Canadian adults followed during the acute phase of their COVID illness and 6 months following infection, found that higher plasma taurine levels at the time of illness were associated with lower rates of adverse events from infection, including symptoms of long COVID or PCC. Now, this was one study that has not yet been replicated as far as I can find, and in particular, pediatric patients were not included in this study, where the median age was 62 years old. And it's again important to point out that this was not a therapeutic study, so even though these findings are interesting, there's no data to suggest that administering taurine supplementation at the time of an acute COVID illness is going to have any impact on the development of later symptoms. But certainly this is an interesting field to watch. Our second question today comes from a member who asks, as we approach mosquito season in Arizona, what are your recommendations for clinicians and parents to reduce the spread of mosquito-borne illnesses like dengue? Now, Dr. Price and I both love vector-borne diseases, so listeners have probably heard us answer similar questions before, but as we come up on summer, I think it's great to review recommendations for mosquito avoidance. Because the question specifically asked about mosquitoes in Arizona, we're going to focus on those species that are local to our state. But the good news is the recommendations we're going to go through apply to most mosquito-borne illnesses. So even families traveling to other parts of the country or world, these recommendations are wonderful to review with families in advance of the summer. Here in Arizona, the two main mosquito species that we have to worry about are the Culex and the Aedes aegypti. The Culex mosquito tends to live and breed in stagnant water, including irrigation ponds, and it transmits arboviruses, including West Nile virus, Western equine encephalitis, and St. Louis encephalitis virus. The Aedes aegypti mosquito is originally from the tropics, but has expanded over time into Arizona. And this mosquito transmits yellow fever, West Nile virus, and can also transmit dengue. This mosquito can only fly short distances, so they tend to live close to human dwellings where they can obtain blood meals. And they can breed in standing water in small volumes in things such as old tires, planters, or puddles in the yard, which will come up when we talk about mitigation efforts later. Historically, the mosquito that transmits malaria and can transmit yellow fever, called the Anopheles, was in Arizona, but thankfully this mosquito was controlled and eliminated with abatement efforts in the post-war era in the mid-20th century. Thankfully, the diseases that are transmitted by mosquitoes are relatively rare in pediatric medicine, but because most of them don't have a targeted treatment, avoidance of mosquitoes and vector-borne diseases is paramount. When we talk about mosquito avoidance considerations, they include both personal protective steps and also mitigation efforts that families can take at their residence. So, for example, when it comes to personal prevention, the mainstay is going to be insect repellent with an EPA-approved product such as DEET or picaridin. Now, there's a wonderful EPA site called, quote, "Find repellent that is right for you," end quote, where families can go and answer questions about their preferences for insect repellent so that they can find the right product for them and their family. When selecting a product, it's important that you tell families they really need to follow the instructions on the label, because how frequently it needs to be reapplied depends on both the product and the concentration of the active ingredient. And when spending time outdoors, it's also important to remind families that sunscreen should be applied first and allowed to dry before insect repellent is applied on top. Also, if the family has opted for a DEET-based repellent, it's important that they know that it should not be used in infants less than 2 months old, because there are concerns that there could be increased cutaneous absorption in that age group. There are insect repellents available that are based on natural compounds, and these are called biorepellents, including oil of eucalyptus, PMD, and a compound called IR3535. Some families prefer this approach because they're based more on natural compounds, but a lot of them do require more frequent application to remain effective. So it's important, again, that the families are aware they really need to follow the product instructions carefully. And if you have a family that is anticipating heavy exposure to mosquitoes from camping or hiking or other outdoor activities, you may want to counsel them to treat their clothing in advance with permethrin, which is available as either a spray or a soak, and doesn't replace products that you spray on the skin such as DEET or picaridin, but is a really useful adjunct when you're experiencing heavy mosquito or tick exposure. Finally, when it comes to personal prevention, it's good to let families know that these mosquitoes tend to feed most often at dusk and dawn, and so if they can avoid outdoor activities during this time frame, they can potentially avoid mosquito exposure. With regard to mosquito abatement around the home, because these mosquitoes breed in standing water, it's good to counsel families to do a review of either their home or apartment property to see if there are any items that can hold standing water that could be cleaned up, to check for possible indoor breeding, and to install and repair screens on the doors and windows to keep mosquitoes out of the household. So make sure to share this information with your patients and their families, because I don't want to see any more West Nile in our hospital. Thanks. And that brings us to our last question of the day. A member asks, according to the CDC, invasive strep infections have more than doubled in the U.S. The rate of infection in children seems to be stable, but the infection rate in adults has increased. Could you speak to the rise in these invasive infections? Well, the first thing to say is that the statement here is correct. We have been seeing a lot more invasive group A strep infections in the last several years, but the actual reasons for it are multifactorial and not quite fully understood at this time. I think anecdotally, I will say that we definitely started seeing an increase in invasive group A strep infections in the hospital starting in the fall and winter of 2022, which coincided with the resurgence that year of respiratory viral infections among children, including influenza, RSV, and COVID-19. Personally in the hospital, I've seen cases of necrotizing pneumonia with empyema, osteoarticular infections such as osteomyelitis, bacteremia without a focus, complicated skin and soft tissue infections with myositis, and invasive head and neck infections. Thankfully, despite the number of these infections, I haven't seen any cases of either toxic shock syndrome, necrotizing fasciitis, or thankfully any deaths from invasive group A strep infections among my patients. Now, my presumption was that since respiratory viruses predispose individuals to invasive group A strep because of inflammation in the respiratory epithelium, allowing for easier translocation of the bacteria leading to invasive infections, that the resurgence of respiratory viruses following easing of COVID mitigation efforts was really what was the primary driver of the increase in invasive group A strep. And there have been some studies since that time that have validated this assumption. So, for example, there was an article in MMWR in March of 2023 that evaluated the increasing incidence of invasive group A strep cases in Minnesota and Colorado. And they demonstrated that the timing of this increased incidence really coincided directly with the increases in respiratory viruses in the community during that prior winter. Now, the authors concluded that the combination of increased respiratory viruses and reduced exposure to group A strep among children during the COVID lockdown also led to the decreased development of protective immunity, which also helped predispose patients to invasive group A strep. And a more recent study published in JAMA Network Open just in April of this year looked at the changing incidence of invasive group A strep among children in Toronto, Canada from 1992 to 2023. And in this study, the authors found that invasive group A strep declined by about half during the COVID pandemic, with rates increasing since that time, and rates in 2023 actually higher than pre-pandemic levels. In this study, the authors also looked at the clinical presentations and found that the most common syndromes patients experienced were skin and soft tissue infections and bacteremia without a focus. They also looked at the specific M types. So if you remember, the M type, or EMM, is the gene in the strep species that encodes the surface M protein antigen. And what the authors found was that during this period, there was an emergence of a relatively newer M1 variant named the M1 UK variant, which was more likely to be associated in this study with pneumonia or lower respiratory tract infection and ICU admission. Encouragingly, for those people who have not been following vaccinology, there is a 30-valent group A strep vaccine that is currently in development, and thankfully all strains of the invasive group A strep species identified in this Canadian study are variants included in the vaccine. So if that vaccine performs well in studies, the good news is that it should protect fairly well against the majority of invasive species that have at least been described in this study. So at least based on the data that I'm aware of, it looks as if the increased incidence is the result of many factors following the COVID pandemic, including increase in respiratory viruses after easing of pandemic restrictions, a lack of protective immunity with no exposure to group A strep during the same lockdown period, and the emergence of potentially more virulent group A strep strains playing a partial role. And going back to the original question, the writer asked specifically about adult infections, and while the studies I cited are focused more on pediatric medicine, in reviewing the literature briefly among adult patients, it appears as if the presumption is that these same factors are what has led to an increased incidence among adults as well. But I have to admit that because I'm a pediatrician, I didn't spend as much time looking at adult data, and I apologize for that. And that's it for another episode of ID Talk. Thanks again for listening. Remember, AzAAP members can submit questions for future episodes to id@azaap.org. The AzAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services block grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.